Thanks for joining us today. In this presentation, you'll learn about how we've built a strategy to use globally to improve antenatal care. Let's get started. Our strategy will be using a human factors analysis to improve ultrasound estimated fetal weight. During this presentation, we will present a case study, then outline our systematic and holistic strategy to identify and prioritize the key drivers of inaccurate estimated fetal weight. We will identify stakeholders, propose a method and cadence of communication, explain how the human factors framework can be used, and recommend a model for change management. Meet Jane. She's 32 weeks pregnant and was sent by her obstetrician for an ultrasound. The scan shows that the baby's estimated fetal weight is above the 90th percentile, so is classified as large for gestational age. Jane has had a healthy pregnancy. She finds this news distressing. Jane's obstetrician explains that babies who are large for gestational age can have complications during labor and delivery. Her obstetrician has suggested bi-weekly follow-up ultrasounds. Even though Jane was hoping for a vaginal delivery, her obstetrician has recommended a cesarean delivery. Jane undergoes a C-section at 39 weeks. Her baby is born healthy with a birth weight in the 70th percentile.
How did this happen? Why did Jane undergo unnecessary investigations like additional ultrasounds and unnecessary interventions like an elective C-section? According to the literature, estimated fetal weight with ultrasound should be within 10% of the actual birth weight, but inaccuracies remain a challenge for many centers. Inaccurate measurements can lead to unnecessary interventions, investigations, and excess healthcare spending, just like we saw with Jane. Likewise, inaccurate measurements may not indicate when the baby's size warrants additional investigations and interventions. Canada tracks perinatal health indicators, and the most recent data from 2017 shows that 9% of babies were born small for gestational age, and an additional 9% of babies were born large for gestational age. This means that over 18% of babies born in Canada need additional investigations and interventions to optimize antenatal outcomes. We don't know how many mothers and babies undergo additional procedures when they receive a false positive abnormal weight diagnosis, just like we saw with Jane. Local data suggests that during 1 year, over 20% of cases at a single site in Ontario had estimated fetal weights that were more than 10% different than the actual birth weights. This is outside of the acceptable limit of error. Publications show that inaccurate sonographic estimated fetal weights remain a challenge faced globally with antenatal care. The Ottawa research team knew that there was a problem, but the literature does not propose any systematic or holistic method for identifying and prioritizing the key drivers of inaccurate fetal weight measurements.
Our group has proposed a strategy to identify and prioritize the key drivers of inaccurate sonographic estimated fetal weight. This strategy will provide the foundational steps that a center could take to uncover improvement opportunities which would lead to more accurate fetal weight measurements. Our strategy begins with the identification of key stakeholders. These include members of the sonography and radiology departments, the obstetrical team including midwives, information technology and ultrasound manufacturers, the site's quality improvement department, and the hospital administrators who will be included for corporate management and oversight. Once stakeholders are identified, our strategy outlines a cadence of communication to engage stakeholders as project supporters. A combination of in-person and virtual meetings, email communications, a posted scoreboard, and written reports will be used as accessible means to understanding and supporting this quality improvement strategy. An in-person kickoff meeting will be used to gain support and enthusiasm with stakeholders. Using organizational behavioral concepts such as the program theory and SBAR are suggested as means to facilitate clear and concise messaging. Program theory suggests communicating the purpose of a project using if, then, and so statements. For example, if we can improve the accuracy of estimated fetal weight, then we can improve antenatal clinical decision-making, so we can improve maternal and fetal outcomes.
Just culture focuses on process and procedures rather than people and problems. We suggest using just culture as a method to ensure stakeholders do not feel shamed or blamed. We want to engage stakeholders as subject matter experts and solution finders. We present the message of measurements matter and 5 calls to action so stakeholders know how they can help. Number 1, understand and follow the estimated fetal weight protocol. Number 2, understand how estimated fetal weight measurements are used. This is important as clinical decisions are made based on these measurements. Number 3, actively participate in this initiative by engaging with other stakeholders and data collectors and allowing opportunities for discussion. Number 4, follow departmental trends in estimated fetal weight versus actual body weight. Regular audits will determine if there are improvements in estimated fetal weight accuracy. Number 5, monitoring of equipment and protocols, ensuring equipment is regularly maintained and protocols kept up to date. There will be ample time for stakeholders to ask questions and engage in discussion about the project goals and scope. An email summary will be sent to all stakeholders after each meeting.
Our strategy outlines how to use a human factors approach for data collection and analysis. Based on the MARC framework, our strategy shows how the researchers will observe the process of estimating fetal weight and collect relevant data. Researchers will study the people, tasks, physical environment, and human environment. They will collect data about the physical space, such as the obstetrics clinic, along with information about ultrasound machines. Information will also be collected on the human environment, such as the organizational culture, including team dynamics among the sonographers, radiologists, and obstetricians, and policies that influence the process of estimating fetal weights. The MARC framework uses guiding questions and data collection charts to comprehensively uncover relevant data, whether in person or role-played if patient confidentiality is a concern. The research team will work with sonographers, radiologists, and the obstetrics team to understand how all of these factors are interconnected. For example, mapping of the tasks of the radiologists may uncover that radiologists are using a number of different formulas to calculate estimated fetal weights rather than using a standardized formula. This may be a cause of inaccurate estimated fetal weights. Lack of protocols developed and training for new radiologists hired may be identified. Once the data has been collected, the MARC framework will be used to analyze the fit between the tasks and human capabilities. These can be related to abilities like perception, attention, cognition, situational awareness, motivations, ergonomics, and executive functions. The MARC framework guides researchers through the process of identifying emergent factors, which are dynamics that emerge when there is a mismatch between the requirements of the task and human capabilities. Examples of emergent factors could be distractions and interruptions. Through this data analysis, problems can be identified. For example, radiologists who are overworked have a mismatch between their task of calculating estimated fetal weights accurately and their human capability due to emergent factors such as fatigue and loss of vigilance. Prioritizations of problems is based on the frequency of the problem and the severity of the outcome.
Throughout data collection and analysis, stakeholders will receive project updates monthly at an in-person sonography rounds, followed by email summaries to all stakeholders. Feedback will be welcomed and encouraged. Once problems have been identified and prioritized, our strategy suggests an in-person meeting with all stakeholders to review the findings. Feedback will be requested, questions addressed, and there will be ample time for stakeholder discussion. Mitigations and interventions to address these problems will be planned. To implement changes, our strategy recommends the use of the ADKAR change management model. This model builds awareness of the problem and desire to change, the knowledge about what needs to change and how to change, and develops the ability to change. The last step of ADKAR is reinforcement of the changes. Our cadence of communication using accessible modalities like meetings and emails will facilitate the awareness, desire, knowledge, and ability to change. As described as best practice in the literature, our strategy recommends a monthly audit process for tracking estimated fetal weights compared to actual birth weights and displaying these results in the sonography and obstetrics departments. Our final recommendation is to share the strategy through regional meetings and national and international conferences. This strategy and findings should be published in international journals for knowledge sharing throughout the antenatal community.
Our strategy starts with a communication plan to engage stakeholders and moves through the process of using a human factors approach to problem solving. Organizational behavior concepts help to engage stakeholders and collaborate as a team to improve healthcare quality. It is our goal that this strategy will be used to improve maternal and fetal health outcomes locally at our pilot site in Ottawa, Ontario, and internationally with groups looking to solve problems together and improve healthcare quality worldwide.
created using Powtoon.